Okay. Good morning, everyone. Thank you for joining. Let me share my screen. This is Academy Session 3, which was supposed to take place in March. We moved it to April. That's why it's our fourth in sequence Academy session, but we're sticking to Academy number 3 because that's how you see it on your schedule. So welcome, everyone. Thank you for joining. And before we get started, I just wanted to set up a quick poll to see how you're moving along with progress and to see where people are with their healthy step specialists and practicing billing. So let me just launch the poll here real quick. If you can share your answers about these 3 questions. People are still trickling in. Oh, I didn't launch it. Okay, now you can see the 3 questions. Great. Sorry about that.
Do you want them to answer it now? Is that what you're having them do?
I think, yeah, it's launched. So yeah, people start answering it and it'll, you'll start to see the responses here.
I thought it was better to ask these questions rather than setting up another meeting.
Yeah, exactly. Just so we can see the range of where clinics are at. So we've got in the recruitment stage, some in the credentialing process, 1 credited, contracted already. Yay, we've got some of you billing. This is great. Others not yet. Hopefully after today and your health step specialist being contracted, you'll have hopefully feel more empowered to start doing so. And then not so much the Dyadic services. Okay, great. I'll give it 1 more moment. Okay, wonderful. Thanks, everyone. And I will, oh, sorry, you didn't see the results. Here are the results. I'm talking to myself, apparently, looking at the results a little bit.
That's okay. This billing review will be helpful today, even if we're not quite yet.
All right, thanks, everyone. So without further ado, I'd like to pass it along to Deborah to kick us off.
Good morning, everyone. Thank you for joining us in Academy 3. I know it's not easy to take time out of your day. Just a reminder of the presenters today: Deborah Matthias, that's me, Hoda Shaki, and Sejal Shaw. We are the consultants for First 5 and helping you and your teams implement healthy steps here in Orange County. And then we also have from CalOptima, Carmen Katzroff. She's the Executive Director of Behavioral Health. Ashley Woods, who is the Senior Program Manager for Behavioral Health, and Wendy Manaka will be joining us later, and she's a Claims Administrator. So just wanted to introduce us very quickly. If we go to the next slide. Let's see. Yeah. There. There it is. Just again, we're going to go, this is just the agenda for today. We're going to try to push the agenda a little bit so that we have time for Q&A at the end of the meeting, hopefully reserve 15 to 20 minutes. So this will be a very brief review of the First Academy billing for services. There are new guidance out. They came out March 2025. So we have links here that are available to you, and we'll talk about the changes that were made to the Dyadic services. And then, of course, our focus is on implementing billing for healthy steps and episodic behavioral health visits. We'll just go to the next slide. Sejal put this together, and I thought it was very helpful. One of the things is important to remember that the implementation of healthy steps is concurrent with all of these organizations. So you're kind of the lead on the implementation. So there's a list of the things that you need to achieve. You work with CalOptima, obviously, in provider relations, getting your staff credentialed, getting your behavioral health contract, et cetera. And then healthy steps, you can see the process. Everybody has to go through this process, and it's sequential. They really don't let you go outside the sequence. So I'm hoping everybody are at least signed your network agreements by now. And then First 5 OC, you all have done very well in getting your contracts executed and we'll be talking about your performance metrics and implementing them in High Five probably next month. Okay, hold on. And then just review Academy 1. This is a very high level review. This Cal Early was helpful and helped us look at the contracting process with them. We really made sure that there was some significant detail there. We then went through credentialing. There were a lot of questions about that, and I think they got answered. The credentialing process, is now going through Verisys, and then that is handed off to CalOptima's health quality improvement team, and they'll notify you when your licensed behavioral health provider is credentialed. The next slide. And I know this seems kind of redundant, but we spent a lot of time talking about these dyadic services and their billing codes, but they're very new, obviously, mostly to primary care organizations. So again, we will spend a lot of time on the billing. And then we talk quite a bit about claims overview. If you do not have access to the first Academy PowerPoint, let us know. We have a link that you can go to, or we can send you a hard copy. Okay, next slide, please. Also, we've continued to provide links to the various sources of that will help you with your billing. We did change these links. These are now, even the non-specialty mental health guidance is updated to March 2025. And then the Dyadic services have a new guidance, and those are the links to those two documents. They correlate nicely. It's interesting. The non-specialty mental health guidance references the Dyadic services, but is no longer embedded in that guidance. Great. Next slide, please.
Sure. I'm just going to drop the links really quickly in here for you in case you want to glance at them while we're talking today, because they're in much more detailed. So here they are, and then I can advance this in a second. Okay.
Thank you. And then we're just going to go ahead and move forward with the billing for dyadic care services. Next slide. I think, Coda, this is you. Great.
So thanks, Deborah. So if you look at the guidance for the non-specialty mental health services that I just dropped in the chat, as well as the dyadic services, you're going to see there's a lot of codes, and especially in the non-specialty mental health services, there are a ton of services that are listed there that can be provided. So because this grant is focused on healthy steps and really helping you ramp up this dyadic services program through the healthy steps model, we try to simplify it, and we're really just focusing on the dyadic services that are being provided through your healthy steps model, mostly in well-child visits, but also in between. And then as well as family therapy, because we feel that those are also going to be commonly used or commonly provided services that you can do under the guise of the healthy steps model. So while there are a ton of services on those documents and you can look through them, and many of you will have many of those services also applicable to you, today's focus is really going to be mainly on these two categories: the dyadic services that you do so much in healthy steps, as well as family therapy, psychotherapy that can take place either with or without the child being present. And we'll go into more, CalOptima's team will go into more about that. So the other sort of high level thing that we want you to think about as we're diving into this today is with this new guidance, we hope that this chart can hopefully help you decide which type of service is being billed to where. So kind of in a very basic general nutshell, if a service is behavioral health type mental health service and it's being provided by a behavioral health provider, so we've listed some of these here, but the guidance that I just dropped in the link has a more extensive list of who can provide which service. But generally, if a behavioral health provider is providing obviously behavioral health services, then those services are going to be billed directly to CalOptima once you have a behavioral health contract in place at a fee-for-service schedule. And that goes with these clinicians as well, who are behavioral health clinicians. If your service is being provided by one of your primary care providers and it's a dyadic service, so that puts us in this box, and we'll talk about those dyadic services in more detail. The primary care provider providing that dyadic service is going to bill to your health network, which is what I think you've been doing. only if the primary care provider is trained in mental health, can they then bill a mental health service directly to CalOptima Health under the BH contract on a fee-for-service basis. So I wanted to see if Carmen or Ashley had anything to add there or to correct. Otherwise, I'm going to offer the hand the rest to Carmen and Ashley and let them introduce themselves from the CalOptima team to kind of then dive us in. But we kind of wanted you to get this sort of primary understanding as you're thinking about who's providing it, what's the service, and then based on that, is it going to be billed to the health network or is it going to be billed to CalOptima under the behavioral health contract for a fee-for-service schedule? How did I do, Ashley?
You did a great job. I don't have anything to add. Carmen, do you?
No, I think you did it really well, the visual here. I think the misunderstanding in the past was, you know, the BH providers being directly contracted with CalOptima Health, right? So I think that's the biggest thing, that the clinics or health networks, you know, if you're contracted behavioral health providers, right? You might have contracts with them yourself, but for them to bill behavioral health codes, then they need to have that, you know, be credentialed with us as well. Thank you.
Great. Thank you. So for the next section of slides, we're just kind of going to start diving into these dyadic services codes. We're not going to talk in detail about each one. There are many tables and they're taken from the documents that we just dropped in the chat, but just to kind of give you a sense of the types of services, who can provide them. There's some new limits on some of them in terms of like how many can be provided in a year. So I'm going to hand it off to Carmen and Ashley to take over that piece and they can introduce themselves.
Okay, I think it's me first, right? Ashley and I will kind of jump in and help each other here with the slides. Hi, everyone. Thank you so much for having both myself and Ashley here today. Again, I'm the Executive Director of Behavioral Health Integration here at CalOptima Health, and I'm just so excited and proud of the work that Chris Five and Hoda and Deborah and everyone's been doing related to the Dyadic Services Academy. So just some of this might be a review for some of you and others maybe will be a little bit new, but as far as the dyadic care services, you'll see the ones with the H and the T codes. So the very first four are kind of what I like to refer to as the core, right? Those were the new kind of dyadic care services. So that includes dyadic behavioral health, well child visit, comprehensive community support services, psychoeducational services, and then the dyadic family training and counseling for child development. And then you'll see under dyadic caregiver services, you know, there is different codes that are under the non-specialty mental health already that are for screenings and behavioral health assessments and interventions. So there's some different codes that you'll see there that you might already be familiar with outside of dyadic care that you might be doing with, you know, other members. But the intent of this again is that the dyad being, you know, the member and then the parent or appropriate caregiver, that you're able to work with, you know, both in that dyad. And then family therapy, because what comes out of the dyadic care services, right, when we're talking about in the room, right, when we're talking about the other dyad that exists, which is the physician or other and the behavioral health specialist, you know, out of those assessments and the dyadic behavioral well child visit, you know, then there might be recommendations for additional family therapy that needs to be done, you know, down the hall, right? Not in the room. And so that's where we have the suite of different non-specialty mental health family therapy, such as family therapy with the child present, family therapy without the child present. You have multifamily group psychotherapy. So for some of your practices, you know, you might be having a family group, right, where you're doing different topics or family interaction. And then, of course, here, even though we have it under family therapy, individual therapy, because again, then there might be some need for, individual therapy also for the member or other, and you have the different codes there that can be used. So again, these are not new to non-specialty mental health. We just want to kind of connect them to how you might use them after doing dyadic care, making recommendations for further care. Next slide. And so here a little bit, again, you have I won't go into big detail, right? I think, but we have the different billing code and what the description is. You have the diagnosis code. Really the main thing I want to draw your attention to is under modifiers. So if you go there, I mean, that's really something key that people could potentially forget. And that's what signifies these codes as really being the dyadic service. So that U1 modifier is really the key thing, when you are billing, so to make sure that it gets that proper credit. And then you will see the different frequency limits. Again, those aren't CalOptima rules. Those are just the billing and coding rules that exist for this. Great. And I think also who's joined us today from CalOptima Health is Wendy from our claims. Hi, Wendy. Thank you for joining us today. So I'm just going through some of the codes, and Wendy will jump in then to help, support or correct anything that I might be saying wrong. So again, we have some of the additional billing codes here. We have the T1027, right? The family training and counseling. So again, what was on the other slide, again, very important that it is a U1, right, modifier. And then you have the different dyadic psychoeducational services, the H2027. And again, any diagnosis code can be used. These are billed, so again, uniquely in 15-minute increments. So, they stack, right? So you're just using them as appropriate per each 15 minutes. And then you see the different frequency limit, per year.
Carmen, we got a question is the limit 24 15-minute units or 24 visits? So we heard that it's
yes, and I'm glad Wendy's on because she's much more educated in this than me. So Wendy, when the frequency limit refers to 24 per year, can you please clarify that?
I cannot clarify that for you, Carmen. I tried myself yesterday. My suggestion is that we need to ask either DHCS or RAC, because if you look at the guideline, and I went through it yesterday, in most of the places they put days or they put a year. So my initial thought was when they say 24 per year, that they really mean 24 units per year. But if I'm not sure if you would all agree with that or not, because they didn't put day or year as they do in some of the other documents. And I do think that DHCS may need to clarify that a little bit more for us. But my initial is 24 units, but I couldn't find anything else to say.
Units meaning not the 15 minutes, right? But units meaning the actual H2027, correct?
Yeah,
Let's say.
so
that would be my understanding too, because we have some other codes related to like ABA and some other things that work in units, but they're, so I believe that probably is the case. So I think Deborah and Hodai, what will be good is let's take this down, right? Because again, this might be one where we need to just advocate for a little bit more clarity, here. And what we could do is take that back, like I said, to our regulatory affairs or to DHCS and just say, can we get some additional guidance on this?
Yeah, but I agree with you. That's my initial when I read it and looking at the other regulations that we've come across under this type of service. It tends to go to units, but definitely would ask clarification on that.
I would believe, because 15 minutes, I don't think that would even make clinical sense then with what that means. I think it need to be the units. But I think to everyone too on the call, what you could see here is that this is also newer for us, right? So we're all in this together. Our responsibility though as CalOptima Health, we will make sure that we do get answers and advocate. That's our job here. So we will follow up and we'll make sure that information gets back to all of you, hopefully as soon as possible. That being said, give us grace because we will be at the mercy of getting the answer from the state. Okay. All right. Next slide. So then again, you have some of the other, these are more the screenings, right? And these are really important because in the dyadic care model, right, in the healthy steps model, the whole point of this interaction is to screen early, right? Get involved early and get different issues identified early so you can, help get the member or the caregiver to the appropriate treatment early on or resources. So you have the depression screening and the depression screening, so positive or negative, right? So that just shows whether or not, they're positive for having more, depression or not. And then you see where that's at with the U1 modifier. And then you have the other modifiers, where the parent or caregiver, many times, right, they might not be in the Medi-Cal, right? But the child is. And so why is this important, right? Why are these billing codes important? Because that's what shows the utilization of this. That's what gives your clinics credit for doing these screenings, right? And these screenings are required, as part of kind of the well-child visit, as part of the different quality metrics. So it's really important that you guys are doing, since you're doing the great work, get credit for it, right? Okay, next slide. Then again, here you have a little bit different. So you have the ACEs screening, the G9919 and the G9920, right? So the adverse childhood event, right? We know this is very key in identification as early as possible. There's research and evidence behind just the more adverse child, like the scores on this, they're just more likely to have comorbid chronic, disease in life. The sooner that you catch the trauma and then you can start getting treatment, you have better outcomes for your members. And so again, these are the different codes there, the U1 modifier, or if again, you're doing the parent or caregiver. And I want to stress here clinically how important that is, because the child, their legal guardian or parent, it might also be that, trauma is usually generational, right? It doesn't usually just start necessarily always with the child. And so this is very powerful in doing this screen. And you see that a lot of times then that identification that it might be not just the child if something might have happened, but also the family unit that has experienced trauma or different adverse childhood events. That's going to help you zone in on your clinical treatment plan to help get the proper resources that might need to be for the child, but also potentially, the parent or caregiver. When you help treat their trauma, when you help treat their issues, you're going to have the healthier child, the healthier family. You don't treat the family, you're only going to go so far in that treatment. And that's just, I think, something that I'm probably preaching to the choir. You all know this if you're in practice. All right, next slide. And Hoda and Deborah, you keep me going if I need to speed up or slow down. So,
and Carmen, you don't have to. I think it's important. What you're doing is the most important, codes and services, and you can skip some of these if you want, because everybody has access to this deck.
Yeah, I think I'll just mention, but again, this is, again, the screenings. Better if people say, well, which one should I do? Which one should I not do? I would say clinically, and I'm a licensed clinician, if you don't know, unless you truly know that someone does not have an issue with that, you need to do all of them. Okay, because how would you know then? And people get screenings give people a way to answer questions and do things. A lot of these, especially alcohol and trauma, carry shame with them, right? And people are worried about that. And so this is a great conversation that, have with your clients to say, this is normal. This is a normal part of your health. This is a screening we want to do. We want to identify these things. Please be honest, and if you can get good at that, your clinical staff gets good at this, you can whip through these. You can do these, as part of your practice. So the alcohol misuse screening, right? So you see those again, any diagnosis, and you have the different modifiers and one per day, right? So again, you have these screenings because why is that important? And I'm glad the frequency limits are there, is because the cadence that you're seeing, you might want to you're doing the screenings at different times because again, right, you might be seeing someone on a regular basis. And as you're talking to them, right, this is something you want to see because just because they're not using alcohol at one time doesn't mean that something hasn't changed and all of a sudden now they're doing that. Or if they were, in recovery, well, sometimes people, in recovery, they start, using again. And at the time that you could do a screening and identify that, you could really help someone before it gets too far gone. Next slide. And then here, 96127. So this is the brief emotional behavioral assessment. Again, some of you use those or not. So if you're using that and you're doing kind of that assessment, again, you see that it can be any ICD code when used for the child. And then you do have you have a Z code there. So what's nice there is you could also be using that, for the parent or the caregiver. And then you have the different modifiers and you have the different frequency limits. So I think depending on your practice and who is billing, right? Whether it's you have a central miller, you have someone else that's doing it, it's really important that department, that person, whoever it is, right, is getting acclimated to this, making sure these things are in the system, making sure they have that just like anything else, because that's how you're going to maximize, right, your billing potential for that. And we want you to do that. We want you to get the money for the services you're doing. And so the responsibility on your end is, doing the great care and then billing appropriately for those services. So those of you that have great billers, congrats to you, right? Because great billers help keep great practices going. And our responsibility is to make sure that we get that internally, that we're paying this correctly, right? And that's our commitment to you. Do we always get it right? No, like we said, with new things, there's kinks in the system. But as some of you have seen already, we identified some things early on. We corrected it, right? So you always have our commitment to be working on that. Next slide. So here, smoking and tobacco use cessation and counseling, right? So you have some codes there. You have the one that's broken down by time, 10 minutes and a little bit more. Now you have some of these, right? Health behavior assessments. So again, what you're going to see here and what you already know in your practice, there's many different codes sometimes that you can use for similar activities. So again, that's why it's like a menu, right? We can't dictate to you as a health plan. We're not allowed to say, you must bill this or you need to do this. What we're able and what we're doing is just sharing kind of the menu of options for you. You have to look at what you're clinically doing and what's most appropriate to bill related to that. So you'll have the different health behavior interventions that you might be doing with, the member or with the family and the patient for here, and you could use those codes appropriately. And you see that most of them are 1 per day, any provider, and 6 per day, because again, these are just different interventions that you're doing with, the clients, the members, or the caregivers. And then here, these are ones that you have different, health behavioral assessment or interventions, family without the patient, because again, a lot of times that work might need to be done without, the member there, depending on how young they are. Your interventions might be really centered around the parents, or caregiver or caregivers, right? That's going on within the family. So that's why you also have these codes as an option to use.
So Carmen, I had a question about this code, these health behavior assessment codes, because it's saying that it can be used when related to a diagnosis that's related to child's health, physical health, not their mental health. So I was trying to think of when would be an instance for a birth to 3-year-old where they're having a physical health condition that you would want to do a health behavioral assessment of the parent. And I'm wondering if maybe like at risk for overweight or obesity might be one of those times where you're now doing a more thorough assessment with the family on their behaviors around eating and physical activity and mood and all of those things. Would that be okay? So like your obesity prevention.
Yeah.
Okay.
Yeah, and I mean, the
wonderful.
purpose of this code, really, it's the face-to-face, right? It's different strategies, right? It's about different strategies to try to change family dynamics or family behaviors, right? So exactly what you said, wonderful. So it might be around that, like if you're having obesity, right? You're having that, the family, and maybe the family though needs more education around how to prepare healthy meals, right? Or different things that they might be able to do, related to that healthy activities. And then you might be seeing, oh, wow, they don't have access to healthy food, right? So again, it's kind of driving that if there's different behaviors around that. Children might have asthma or other medical conditions, and maybe there's different family behaviors. Like let's say a child has asthma, but you have both parents in the home smoking. right? So that might be where
Awesome.
some of that education is, or that smoking cessation, right, leads into other things. But, again, we can't assume that everyone knows or doesn't know that something is dangerous or not, or how to change behaviors, right? So yes, it's that those examples would be, those are excellent that you had given.
Excellent. Thanks, Carmen. That's
Mhm.
helpful.
Yep.
So
And then
no
this things, I
codes.
think, again, most people, this is like pretty standard when we talk about psychiatric diagnostic evaluation, right? We have two different codes here. Usually, you have a code that's more for kind of the NDs or the nurse practitioner, et cetera. And you have that which is usually the 90792. And then you have the 90791, which would be folks like myself, masters of licensed clinical, psychologists, so that you have, again, basically this is when you're doing, a full psychosocial, you're doing a diagnostic eval to really, so a lot of people utilize this sometimes as their first, appointment. Again, in the dyadic setting, you might be doing the dyadic code, and then you're like, wow, you know what? It might be the recommendation out of that in the room service. I need to do, right? We need to have a full diagnostic eval. There's a lot going on here, we think, right, with the child and or, family. And that might be then the subsequent visit, after that dyadic care visit to do a full psychiatric diagnostic eval. If you're thinking, or from some screenings where you're trying to get, figure out what is the actual problem or diagnosis, et cetera. Okay.
Thank you for that.
And then, so here again, family therapy codes. And again, this is where the dyadic core codes came out of this, but these have existed. So for many of you that are working in the practice already, if you have a behavioral health professional embedded in your practice, this is stuff that they do on a regular basis. They're doing psychotherapy and they're doing family psychotherapy and, sometimes doing group multifamily group, right? So these again are they're standard non-specialty mental health codes, but these are the things that make the most sense when we were thinking about the dyadic services. Again, based out of doing that, you're going to be treating potentially the member based on age, but also, an individual and family psychotherapy. So these are all the different things you can see. And the one here I'll call out again, that's why you have the different times, because the timing depends on how long you're spending or how your practice. Some practices say, hey, we do everything, we do 60 minutes. That's again, not for us to dictate that. That's per what you deem appropriate. But you do have the different crisis codes. And so psychotherapy for crisis, right? Those usually carry with it. I think those are a little bit more in money. And the reason they are is because when somebody's in more of a crisis state, I mean, you're doing a little bit more intensive work. Sometimes, when I've had to do that, I might be having an hour and a half session with a client, right, to see if something that I could do can get them more stabilized, or, me deciding potentially if they needed to have more emergency services or not, right? So we know that's a more high intensity client, and that's why those sometimes people bill for that psychotherapy for crisis. Okay. And then documentation, I think there was a question though, and while Wendy's on, I'm not sure. Again, and we're going to be trying to come out with more of something in print for like a dyadic service billing guide. We've done this similar when we've had other academies and things like that. Wendy, if you're still on, they were asking, is there limits to billing a dyadic code, example H1011, plus a family therapy code 90846, in the same visit?
I would have to take that back and research it.
Okay. Yeah.
But I'll hand it off and let you know who is going to look that up for you.
Perfect. Thank you. So that's perfect. Just so we capture that. I think Hoda and Deborah will capture whatever's in the chat for everyone, but let's look at the way I'm thinking about this clinically though, right, is in the same visit, right? Usually you would see that you're billing the dyadic code and you're then if you're doing any family therapy, I mean, you usually wouldn't have double of those codes. Doing the family therapy code is like one time that, if you're talking about in the same day, if you're doing that, unless clinically, potentially, I don't know what scenario this would happen, but you have something in the morning, again, I doubt that you're going to have then two separate family things the same day, but maybe later on if they're coming to a family group or coming to a family therapy. So I think what's helpful too in the questions, and maybe as we go on, or if you bring those back to Hood or Deborah, give a clinical example, because I think a clinical example helps the framework better, because then clinically we know what is possible and then how to bill. So I guess I would ask back, what would you be doing here? I'm assuming this is you do the dyadic visit and then you're doing family and you're doing some therapy then right after that. Or you're saying that the family therapy is occurring at the very same time in the dyadic. I think they usually occur a little outside of that. You might want to use another code for like health education or something, but family therapy is usually then very distinct and a separate a separate entity. Okay, so documentation. If you want to go back to the other page, please, just to start out. The documentation. Yeah.
Was going to be a confusing slide. I think we were going to skip this for later.
Oh, you were going to skip it. Okay.
But you have this, I think this has more information for documentation.
Yeah. Okay. Yeah, so people were asking just questions like, what do we need to document around dyadic services? And I guess I would just leave you with the clinical of, you really want to follow the same principles that you do for any of, most of the services that, you would do anyway. So I don't think there's necessarily big standouts here, or big surprises. Date and time and duration of the services, right? Any specific dyadic services rendered, that's probably right. Good to know, like kind of, I always like to say to my teams and documentation internally, your note, right? One note should stand on its own, right? So if you had somebody independent from your practice reading that note, right? Could they get a gist of what happened? If they had to go and read 20 other notes, then the note's probably not so great. Right. So again, in a summary, and it doesn't have to be detailed and huge, but if you were doing one of the which dyadic services, right, was maybe happening, and if you want to put the billing code, if not, what it is, but what happened, right? Any of the identified needs or issues to be addressed, including any follow-up. So let's say in the dyadic session, right, with the physician, there was maybe an identification for some additional screening, right? So maybe there was some concerns about what was being said, about, potential need for screening for some additional screening for depression and potential family follow-up, right? That's what I would put in there, right? If there was going to be potential family therapy. So again, whatever was kind of coming out of that dyadic visit with potential needs or things and what was going to be recommended, explanation of medical necessity. So again, I think there what that means is kind of justifying the visit. So the dyadic service visit, right? What was the visit about? What did they come in for presenting, right? What was discussed. So again, just like any other business, note, a documentation around progress note. And then discussion or creation of a dyadic service plan, if it's applicable. Again, maybe it's going to be done at, after that session, right? So that might be where the follow-up care is recommended. But if something was already kind of created about what the service plan was going to be, right? Again, the physician may be saying something, the BH professional, then you might want to notate that there. And then any other information that's necessary, right? That you feel clinically relevant or necessary in the note. And then if the child was not present, include the reason why and how the service is to benefit the child, right? So the goal or what it was around. And again, I think you all know good clinical guidelines, you include the least amount of information, but enough to say what it is, right? Protecting people. So again, I think this follows the regular kind of standard documentation, but I think what's important here is which dyadic services rendered, if like key points, and kind of that follow-up plan or follow-up actions.
Thanks, Carmen. So we're going to shift a little bit into putting into practice sort of what we've talked about with the codes and sharing a couple of scenarios here, a few scenarios to just kind of get you thinking about who's providing the service, what type of service is it, and what codes you might consider billing for. So Sejal is going to talk about this, which kind of is another way to look at assisting you to figure out, okay, well, who's providing the service and where are we billing it to? So,
thank you. My name is Sejal, and I am one of the first 5 consultants working with Deborah and Oda. So this is just another way of looking at how we are billing the services depending on who's the provider. You heard this information in a different way earlier, but this is a visual diagram of it, that when the Dyadic behavioral health well-child visit happens, then depending on who's providing that care, if that is a primary care physician, then the billing goes to the medical network. And if the care is provided by the behavioral health provider, and there's a long list of who those providers are in this big blue box, then the billing goes directly to CalOptima as per your behavioral health contract. Just so you know that it is the carved out contract for the behavioral health provider, behavioral health contract. So that goes under the fee for service fee schedule there. And this is an iterative process. So every time that care has happened, you're gonna follow this algorithm, who's providing the care, and depending on that, the billing goes. So let's go to the next slide. So this is just one example of what that care could look like within your clinical practice. So one example here is behavioral health visit, a well-child visit at 4 months, and when there is no behavioral health concern identified. This is a visual steps of what that could look like into your clinical practice. The very first box is, the parent is bringing the child for pediatric office for well-child visit. You'll see the code that are just an example of what could that billing code could look like. And then at that point, if the parent has not completed the screening tool ahead of time, they can do that within the waiting area. But what we are trying to instill upon here is that the Healthy Step specialist, the behavioral health provider, introduces herself or himself at that point to the family as a part of the clinical team. So just start building that relationship early on for the behavioral health provider. Followed by that, the pediatrician provides the well-child visit and does all the screenings that are at 4 months, for example, maternal depression, ACE score screening, etc. And again, at the bottom, there are the examples of the code. But again, this is not just these are just examples of the code. You will be referring to your billing guidelines as per your specific contract. Within the same visit, the pediatrician is also providing the anticipatory guide, guidance on perinatal mental wellness, bonding, positive early childhood developmental outcomes, and then shares the strategy to reduce the symptoms for postpartum depression. So that visit concludes with the physician, and then the Healthy Steps specialist also provides and documents the Dyadic behavioral health intake at that point. As I said earlier, there is that established relationship early on, and then in this visit, the provider, the behavioral health provider, also provides parenting education on crying, sleep routines, etc. And there are some suggested codes at the bottom there too. So this whole process is just a visual flow of the work within the clinic, and this is an iterative process, meaning every time there's a well-child visit, this flow occurs, and in between is that the concerns are identified. So this is just a very, very high-level view of what you can expect in your clinical practice. Let's go to the next slide, and Hoda can take you to the example when there is a concern identified in terms of behavioral health or the developmental.
You guys, we need to speed it up a little so we have time for QA. All right.
Sure. Yeah. So this is, thank you, Sejal. So this is another example. Let's say that you have a child who's coming in for their 9-month well-child visit. So they're having their well-child visit as well as a DBH visit. So the primary care provider is going to provide the well-child visit. Anything that the primary care provider is providing here, they're reviewing screening results. So if the primary care is providing it, they're going to be billing it to their health network. And then whatever the behavioral health provider is providing is going to be billed to the CalOptima under behavioral health. So in this example, the pediatric provider is providing psychoeducational services. So just again, anticipatory guidance, education, because they might have seen or maybe early signs of development, needs to kind of support additional development, and they realize that there's some social determinants of health needs. So they might provide information about why it's important to take care of these things early on, because it's better for the child's well-being. And that might be their way to kind of connect the family with the Healthy Step specialist to say, you know, my colleague would like to continue to help you to support your needs around these types of things or learn different strategies. And we could provide you with a resource in the community or connect you, provide a warm handoff so that you can meet some of your social determinants of health needs. So then you'll see here, like what types of services can be billed for the support that the Healthy Step specialist is going to provide. So this one is a little trickier because there's different codes that you can use. So I was going to ask Ashley, if you're still on. I can only see partial screen here to provide an example here when there's a behavioral health concern that's not part of a well child visit and it's just a family that needs to access the Healthy Step specialist for some type of therapy.
Hi, I'm Ashley Woods. I'm the Program Manager Senior supporting behavioral health, ABA services, and school-based services at CalOptima. Pleasure to join you all again. What I really wanted to emphasize here was not so much telling you which codes to use or how to bill it, but more so how to think of behavioral health is very comprehensive. So dyadic services is really just a tip of the iceberg. When we talk about behavioral health professionals and the behavioral health contract, there's so many other codes and services aside from what we touch on here in dyadic services. So if you do have a BH professional in your practice, they're familiar with this. They've already gone through that in their internships and their clinicals. So they know there's a lot more they can do. They're not just restricted to the dyadic services. So keep in mind that you may be screening and identifying an issue, but it may be something that needs to be addressed with that member or that parent ongoing. It may take a year. It may take many visits. So keep in mind, if you are a medical professional and you're not a BH professional, you can make an appropriate referral back to CalOptima to connect that member with an appropriate BH provider to see them ongoing. Or if you do have a BH professional in your office, they can provide that ongoing care. So of course, bill your dyadic services as appropriate when you're doing your screenings, when it is either a well child visit or just, another type of visit, and you're doing those screenings and you're identifying those concerns. But just know that you're not limited to just billing dyadic services, that you can move into regular ongoing individual therapy, regular ongoing family therapy, as long as medical necessity, is met for the services that you're offering. Don't just restrict yourself just to thinking, oh, it's dyadic, so I can only do this 5 times. You can only use the U1 modifier or the dyadic modifier that number of times. But a lot of these services, as Carmen mentioned, do expand beyond just dyadic care services. And you'll see that as well if you do have a BH professional in your contract. You'll see that a lot of the codes are spelled out, and there's many more that we haven't touched on. So you have a lot of options when you do have that BH professional in your practice to provide a wider scope of services and care.
Thank you, Ashley.
You're
It's really
welcome.
helpful. So the next 4 slides are kind of a summary of the updated the dyadic services guidelines that we shared in the chat earlier. And you'll want to take a look because they talk about 2 different scenarios of how to bill for different cases depending on whether or not the parent is also a Medi-Cal member. So I think for the majority of your clinics, the likelihood is that you're providing the service to the child and the parent is likely not a client in your facility. And so you're going to be billing under the child's Medi-Cal. There's also an example where the parent is a patient and is a Medi-Cal member, and it talks about in case 2 sort of where to bill for that. But I think in order to save time so that we can just have time for questions, we'll just talk about this one case scenario. And so Carmen, if you're able to talk about it. So this slide talks about what services are being provided at this visit by which provider. And then the next slide will sort of show you how to bill for those services.
You want me to walk through this, right?
Yeah, if you don't mind.
Sure. So the first case here, right, parent is not a Medi-Cal member. We know that this happens many times, right? So they're not enrolled. They come to your FQHC, right, with their child who is enrolled in Medi-Cal. So this is for the medical well child visit, right? The services are provided by the primary care provider. So they do the well child visit. And then the Healthy Steps specialist, AKA, right, the behavioral health person, right, is doing some, like we said, a DBH screening. They're doing a dyadic family training and counseling for child development. They spend about 30 minutes doing that. And then they do a health behavioral assessment to the parent or the caregiver with the child in the room. So you see there's like many things happening, right? The well child visit is that core visit. And then you have by the medical provider. And then you have the 3 other things that are happening by the BH professional in the room, right? At the same time. Okay, next slide. Okay. So the child, right, on the claim form, so where you see again, so like we said, many things happen. That's the whole point of this, right, is the BH. So when we talk about that, the screening that's happening, right, again, modifier U1 is very important here. If applicable, we have, right, submitting the PPS wrap claim for the well child visit. And then you have the applicable dyadic service code on the claim, right? You want to make sure you have the right codes for the right clinical service that you provided or services that were done, okay? So that was for the child. Then you have the parent and caregiver, right? From the other slide, again, you had the dyadic training and counseling, right? You did 30 minutes. There was the 2 units, right? Why 2 units? Because they're in 15-minute increments, right? So you did 30 minutes of that family training and counseling during that visit, and also a health behavioral assessment. So you see here where it's really important, and that's why also that documentation, I'll just go back, it's really important where you are, saying what happened. And as you see with your BH professionals, they're multi-skilled. They're doing a lot of things in the visits, right? So they can get credit for the different things that they're doing. Okay.
Awesome. Thank you so much, Carmen. So
Sure.
I think we're going to jump to questions. We'll leave this up. You guys can glance at the
Yeah, and then I
billing
see
tips.
something in the chat too.
Yes.
Yeah.
If we need additional services after maximizing dyadic benefit, would another authorization be needed? I don't think there's any authorization needed for a dyadic services, and most of the I guess this question I need more clarity on. Everything depends on what service you're thinking about doing, okay? So, and by who, right? So again, you would follow your normal billing and guidelines related to the clinical service that you want to do. So I can just give you an example. Let's say your BH professional, right? Or the MD, just again, as part of all of this that happened, determines like, gosh, I think we need some psychological testing. I'm not sure, right? Or the BH professional, when you're meeting with someone, is saying, gosh, there might be some developmental things going on here. I'm not sure if this is autism, maybe. I'll give you this example, or ADHD, right? Attention deficit, and you want to get, you need to refer for some psych testing. If your practice does that and you have a psychologist or other that's doing that, those services require prior auth, or they might need to just come back to CalOptima if you don't have that provider. So I guess the simplest way I can ask it is, you have to look at the different codes you possibly want to do and see if those require prior authorization or not. And that might be from your health network if they're medical type of services, or if they need things like home health or OT or PT or things like that. Or if they're behavioral health in nature, then there's certain things that require authorization. And you would, on CalOptima, we can provide that after. There is prior authorization list codes for providers. It's on our website under the provider tab, and you can see the prior auth list for both Medi-Cal services and OneCare. And then here are some other billing tips, right? Refer to your clinic's BH contract or your CalOptima provider relations contact, right? So Ashley, I don't know if you want to just go through this a little bit or if you want me to.
So I also typed in a response to that previous question, and I will go ahead and include the links for the prior authorization page that Carmen was speaking of, we do tell you which codes require prior auth. And then we also have a BH hotline that you can call into as well and speak with a BH professional. If you have questions or you're not sure how to proceed, they can advise you. So as far as billing tips, I always suggest that you, a lot of questions we get will be very specific to the provider, to the member that they're treating. If you got a denied claim, we'll need to look into why. So sometimes it's hard to answer questions generally. So if you do have a BH contract, you should also have a provider relations representative assigned to your group. And you're going to always want them to be your starting point. So reach out to your provider relations rep, let them know, hey, I got some claims denied and I need assistance. I want to know, what happened? Did I bill it incorrectly? I need to kind of troubleshoot that. And then from there, your PR rep's job is to go internally and bring claims into the discussion, bring contracting into the discussion if needed, and help you troubleshoot that issue. So definitely utilize that resource. And I would assume you have the same for your medical contracts. You probably do have a provider relations representative who can assist you. So definitely utilize that resource when you have claims questions that you need to look deeper into, or if you have questions about your contract, same thing.
Can
Billing
I
with
interrupt you about that question real quick? This is, I think
Yeah.
we have a related question in the chat. So is the behavioral health hotline, that's different than the provider relations link, right?
Yeah, let me
It
clarify
is.
that. Yeah, for the
Okay,
BH line. So I want to make sure two people understand, the hotline. So it's not a crisis line, right? I just want to make sure because the word hotline, I want to just
Yeah.
clarify. So the behavioral health line that we have,
Right.
and I will put it in the chat, which
I'll go
is
ahead and do that, Carmen.
Oh,
while
thank you so much.
Yeah,
Yeah.
I'm taking care
So
of it.
it is first answered by customer service reps, right? So just if you do call, just make sure, or you can advise members that you need to make sure that you have the full name of the member, the date of birth, and the Medi-Cal identifier, the SIN number. That's important just so that when you're calling, they're always going to ask who you're calling about or help. And that is, again, for CalOptima Health members. So if you have, general questions around behavioral health services, it's provider facing or member facing. We help people if they need to get linked to in-network providers. We also do the required for Medi-Cal levels of care screening. So if you have people that are new, so out of the Dyadic services, if you're like, wow, we need to get more help than what our office can provide, this person hasn't really had BH services before, then they can help do a screening. And that is from the Department of Healthcare Services screening, which determines whether they access our network for mild to moderate, or if you have someone like you feel like, oh, they're kind of I think they're getting a little bit more severe. Maybe they're going towards a hospitalization. Again, that level of care screening can be done. And if they're deemed to have more severe impairment, then many times we're referring over to our Orange County healthcare agencies to do specialty mental health, right? But I think in your practices, your BH professional is going to be the one that's most knowledgeable about that, because they'll be able to treat, and they should know kind of that limited line where they see that someone's progressing beyond the outpatient type of services or the mild to moderate services that they can do, and that they might need more intensive services.
Okay, thank you. And I see another question here following about where to put in the note the behavioral health or dyadic service. Can it be embedded in the pediatrician's medical note? So I'm thinking it depends on who's providing the service, but I'd love for you to answer that too.
Yeah, I think you said it correctly. I mean, again, depending on how your EHRs work, right? Some of them work where the actual, let's say when I did this, and it was a long time ago, but right, the MD, right, you're putting in the notes, and then potentially if your BH professional's putting in the notes. So I think it's just important. Absolutely, it can be in the physician's note, but then it should be, just clear that what physician did versus what the BH, who, right? We should be able to see in your notes, right, if audited, who did what, right? But it absolutely can be in there, but there should be very clear of who did what, right? So from a physician standpoint, the physician might be giving their expertise and their overall kind of summary of things too. And then you might have the very specific behavioral health professional. They should be having their notes in their section for any clinical services they did. But but you might have the whole note that has kind of the overall clinical and summary and recommendation for treatment. So we
Okay.
don't dictate again how you do it. It just should be clear of who's doing what, kind of what happened and next steps. And if you can, be able to show that in documentation, that's just good documentation practices. I think it's always like, ask yourself, if we were audited and they had to pull the chart for this, would they be able to see who clearly did what and when? Then you've covered yourself.
We had one more question, I think earlier. Are there limits to billing the Dyadic code H1011 plus the family therapy code 90846 in the same visit?
Yeah, that was one that Wendy, like we had to take back to get more, to get some guidance on that. Yeah.
Great. I don't see any more questions coming in, and it's 10:01, so we wanted to honor everybody's time. Thank you so much to the CalOptima team for joining and clarifying so much. I learn so much every time. Thank you, everybody, for participating. So our next session is going to be on May 8th. It's an in-person session. It's part 2 of reflective practice and supervision. So this would be a great session for your clinicians to come to. And I will send out an RSVP link and any dietary requests that we should be aware of. But today's presentation will be recorded, and we'll send out the slides as well. I think keep sending us your questions, and we'll forward those to CalOptima and try to get back to you sort of like a document, and that we can also post on our Academy page so that you can refer back to the information you received. But thank you, everybody, so much for your time. Have a great rest of your day, and have a great weekend.
Thank you for attending. Appreciate it.
Thanks, everyone.
Bye-bye.
Bye-bye. Great questions.
Thanks, everyone. Thanks, Ashley.
Yeah, that was good. You learned a lot from it, huh?
Thank you.
Oh, yes.
Y'all have a great day.
You too.
You
Beth.
too. Take
Thank
care,
you.
everyone. Bye.
Bye-bye.
Bye.